Just with special interest in pediatric ophthalmology, strabismus, cataract, and medical retina. He has trained at renowned centers in Mumbai, Delhi, Auckland, and Toronto, and he has completed 2 fellowships in pediatric ophthalmology and strabismus at the University of Auckland and the Hospital for Sick Children at University of Toronto. Presently, he is an assistant professor and staff ophthalmologist at the Northern Ontario School of Medicine and Tampa Bay Regional Health Sciences Center at Thunder Bay, Ontario. Dr. Bhambhwani is also involved in many rural initiatives such as the CNIB IVAN. And so without further ado, I'd love to pass it on to Dr. Bhambhwani. Thank you.
Thanks, Sean and Hamza. Thanks for the invitation and good evening, everyone. Glad to be here. And I was just saying before this excellent initiative, I was looking at the NorthernVision's website and it looked very, very professional. So good job, guys. So I'm just going to share my screen. Okay, so you guys can see the presentation? Okay, perfect. All right, so my talk is going to be on practicing ophthalmology in smaller communities, so Thunder Bay or smaller. And I work at the Thunder Bay Regional Health Sciences Center, and I'm attached to the Northern Ontario School of Medicine in Thunder Bay, Ontario. These are just my disclosures. So I get some grant support from the Northern Ontario Academic Medicine Association, that is NOAMA. Just a second. Yeah, and I also get some grant support from Orbis Canada. All right, so I just wanted to give you some context for those of you who do not know. So this is Ontario, obviously in Canada, and this is Thunder Bay. And if you look at this map here, it kind of shows us the division between Northern Ontario and Southern Ontario. So this green portion here is Southern Ontario, and the orange portion here is Northern Ontario. So we can see that the area that Southern Ontario occupies is actually much, much smaller than what Northern Ontario occupies. And we all obviously know that the population of the South is much more than the North. So we have a more dense population, obviously, in Southern Ontario and a very scattered population, and it's scattered across a vast domain in the North. And just to show you again, this is Lake Superior. So Thunder Bay is located on Lake Superior, but it's also interesting to see that even though Thunder Bay is Northern Ontario, there is so much more even north of Thunder Bay in Ontario. So there are large regions even north of Thunder Bay. All right, so this is the Thunder Bay Regional Health Sciences Center. It's a tertiary referral center in Thunder Bay. And we also have the Northern Ontario School of Medicine University, the Thunder Bay campus located here in Thunder Bay. These are just some pictures of Thunder Bay. It looks really beautiful, more so in the summer and the fall. The winters, maybe not so much. And so I just wanted to talk a little bit about my clinical journey, just to give you a little bit of context as to how I landed up in Thunder Bay. So I actually started my medical school in India. I completed my residency in India as well. And then I was in Auckland in New Zealand for a fellowship in pediatric ophthalmology and strabismus. And after that, I was working as staff ophthalmologist in India for some time. And I came to Canada for my second fellowship in pediatric ophthalmology and strabismus, and that was done at the Hospital for Sick Children, so Sick Kids at Toronto. And after I finished my fellowship there, I joined Thunder Bay and the Northern Ontario School of Medicine. So I know Shan was talking about Dr. Miriskandari. So that picture actually has Dr. Miriskandari in the background. He was one of my mentors at Sick Kids. So this is from my time there. So just a brief overview of what we are going to talk about in this presentation. So I wanted to discuss practicing ophthalmology in smaller communities and divide it into clinical practice, research, teaching, and administration. And within clinical practice, I wanted to talk a little bit about practicing out of the office, so an office-based practice. Then I wanted to move on to practice out of the hospital. And then I wanted to discuss a little bit about community outreach. So just basically trying to provide care closer to home for other communities that depend on Thunder Bay for ophthalmology care. And then in research, I wanted to discuss a project that we've been on the brink of starting in Thunder Bay, and it is on it is in the area of artificial intelligence in ophthalmology, and this is an area obviously very close to my heart, and it is one of my areas of interest. And then in teaching, I wanted to talk a little bit about simulation-based ophthalmology training, again, something that we are trying to start in Thunder Bay. And then we'll talk about some areas of administration as well. So starting with clinical practice, so I actually practice at, just give me a second. Yeah, so I actually practice at the Port Arthur Clinic in Thunder Bay, and as most physicians in Northern Ontario will tell you, we all run very busy practices, very high numbers of patients are seen by most of us every day. And one of the reasons behind this obviously is physician shortages in the north. And this has been a long-running issue. There have been shortages of not just family physicians, but also all specialists in the north for a very long time. And we can just see the stats from 2004, where they talk about 20% of Canadians living in rural areas, but only about 9% of physicians providing care to these areas. And it's quite bad for family physicians, but it's even worse for specialists, where you can see that it's only about 2% of specialists practicing in these areas, whereas 20% of the Canadian population is actually residing here. So with this busy practice, one of the things that comes with it is that you see the entire spectrum of conditions. You would see some of the very rare disorders, and you'd see almost all their presentations from the mildest form to the most severe form. And that is one of the most satisfying areas of practicing in the north, is you get to see a lot and you get to treat a lot. Just a short story from my first week of practice here in Thunder Bay was that it was, I think, my second or third day of starting to work in Thunder Bay in the office. And I'd seen this young male, about 16, 17 years old, who came to the office only with something that we call convergence retraction nystagmus, which is one of the features that we see in dorsal midbrain syndrome. And he didn't have anything else, no other symptoms, no signs, just convergence retraction nystagmus. And I examined him, and I mean, it just seemed really weird that in your first week of practice, you're seeing this patient who doesn't have anything else besides this rare symptom of a rare condition. And then we'd ordered imaging for him, and they had actually found a tumor in the dorsal midbrain. And I think some of the people who are on this presentation have actually seen the videos of the patient with this condition. So it just shows that you get to see a lot here with the busy practice. And also, most ophthalmologists here would work as either only comprehensive ophthalmologists, or they would do comprehensive ophthalmology along with a subspecialty. So we don't have any ophthalmologist in Thunder Bay who's doing only a subspecialty. And one of the reasons for that is because all of us have to cover call at the hospital. And basically with covering call, you end up seeing and treating almost everything. So we'd seen the map before, and we'd talked about Thunder Bay as a referral center for almost the entire Northwest Ontario, at least with respect to ophthalmology care. So we obviously cater to a very large geographic area with its scattered populations. So also, a lot of these populations reside in very remote and rural communities, even further north of Thunder Bay. So we cater to a very variable population demographic and different cultures as well. One of the things that I at least wasn't aware of when I was working at Sick Kids in Toronto is how much access to care or being close to the point of care is taken for granted. For somebody in a bigger city in Canada, say Toronto or Vancouver or Ottawa, if you needed access to care, you could basically drive to a hospital in 15 minutes, 30 minutes, 45 minutes. And there may be, you may end up waiting some time in the ER, but it is easy to get to the point of care at least. Whereas a lot of people who live in these communities unfortunately don't have that luxury. And it's sometimes very easy to overlook this when you're busy in your office and you're going through one patient after the other. But I mean, I've had patients referred to me from all over the north of Ontario, and there have been times where I have seen children who, one child who would come to me had allergic conjunctivitis, and the conjunctivitis was so severe that he couldn't open his eyes, and nobody close to home. There was no optometrist, there was no ophthalmologist. The nurses there couldn't get him to open his eyes, and he flew from his remote community with his mom to a place called Sioux Lookout, which is about 4 or 5 hours from Toronto. Then I had to spend the night in Sioux Lookout because the next flight out of Sioux Lookout to Thunder Bay was the next morning. So he stayed overnight in Sioux Lookout, then flew to Thunder Bay, and then drove to my office after that. So this was basically 24 hours of travel to just see me in the office for something like allergic conjunctivitis. And so it is quite a difficult situation to be in, and it's important for all of us, if you're ever working in the north, to just try to have some empathy, and it's very easy to forget with busy practices. It's very easy, and I myself may be guilty of it many times, but it's just important to keep that in mind. The picture I put up here is from Orange. So Orange is the air transport, air ambulance service essentially in Northern Ontario. And it's basically a plane that flies from these communities to get patients to the point of care. So along with issues with accessing care because of transport issues and just being in remote communities, there are also just some inherent differences in the way certain diseases present in certain populations, or the frequency with which they occur in certain populations. So for example, it has been shown that in indigenous populations, diabetes is much more common compared to in non-indigenous populations. And correspondingly, these populations are more likely to have diabetic retinopathy compared to non-indigenous populations. And because they don't have access to care to meet recommended standards of the once a year diabetic eye exam with an optometrist or ophthalmologist, a lot of the times these patients end up presenting to us at a very late stage in the course of their diabetic retinopathy. So we see a lot of patients with vitreous hemorrhage, tractional retinal detachments, and very advanced proliferative diabetic retinopathy by the time they come to us, because they've never really had a screening eye exam. Also, I spoke a little bit about cultural diversity. So obviously, any care that we provide in these communities has to be with respect for indigenous ideas of health and wellness. And it's again something that is easy to overlook, easy to forget, and something that we, the way we've grown up sometimes, or the way we've lived our lives sometimes, it may not be something that we think of every day, but important to consider indigenous ideas of health and wellness when providing options for treatment, especially for these communities. And my personal experience has been that if you want to start any program in indigenous communities, or if you want any sort of health initiative to start in these communities, it can only be done with the participation of the community, and finally with the community taking up leadership of the project. And only then will a project in the long run be successful. So again, out of office-based practice, so this is a picture of my colleagues. I work with Dr. Francis and Dr. Durjan. So we are partners at our practice. And I think relationship with your colleagues is important everywhere, but it becomes even more important in these smaller communities because your colleagues are going to help you out in times of need. There are so many times you need opinions from other specialists, and you need referrals or consults from other specialists, and there are so many times that everyone is overworked, everyone's busy, waiting lists are long, and then you sometimes have to call them, and you know them personally, and then they would get some special favors done for you or see patients for you. And finally, if you have good relationship with your colleagues, it ultimately leads to better patient care. Along with the clinical side of office-based practice, another side which comes in is the financial management of your practice. So again, in the north, the resource constraints are always there. There is difficulty in finding skilled personnel for your office, to find ophthalmic technicians or orthoptists. You may even have to think about things like whether you should buy a particular equipment or not for your practice, because ophthalmology equipment is unfortunately extremely expensive. And sometimes you have to think about questions like whether there is any return, or at least the equipment being able to pay for itself in the long run. So sometimes these questions are also important, and in the smaller communities where you may not be dealing with that niche of patients as often. After that, I would just want to move on to hospital-based practice. So we, as ophthalmologists in Thunder Bay, we perform lasers at the Thunder Bay Regional Health Sciences Center. We also perform minor and major eye surgeries there. So we have cataract surgeries, we have strabismus surgeries, we have glaucoma surgeries. So all of these surgeries are performed at Thunder Bay. We provide on-call services for the whole of Northwestern Ontario, and as we were discussing, we don't have a residency or a fellowship program in ophthalmology in Thunder Bay. So it basically means that the staff is on their own for the most part, and you basically take calls on your own, you see patients on your own, you arrange follow-up on your own. I, as a pediatric ophthalmologist, also provide services for retinopathy of prematurity screening at the hospital. So I cover the neonatal ICU at the regional. And again, the same thing with the relationship with your colleagues, with nurses, with the hospital administration staff is really important. And one thing that I personally find very satisfying is that you are made to feel that you add a lot of value to the practice and to the hospital, because I think it's probably because we are lesser number of ophthalmologists here for a very large and scattered population. So a lot of the staff from the hospital and even patients are very appreciative of the services that we provide, and that is something that is very satisfying. Resource constraints are always there even at the hospital, and this is Dr. Francis performing some lasers at the hospital, and this is Dr. Dojon and Dr. Skoll. So these are my colleagues there as well, and we are often involved in fundraising efforts because funding is always a challenge at the hospital as well. After this, I wanted to talk a little bit about community outreach. So obviously, there is something to be said for providing care closer to home for patients as much as possible. And there is basically no ophthalmologist north of Thunder Bay. So Thunder Bay, that is why, is the regional center for Northwestern Ontario. So one of the ways that we can provide care closer to where patients live is by taking our practice to the patients rather than patients coming to our practice. So this program, which is the IVAN program, was started or it was actually under CNIB for the longest time. And now Vision Loss Rehabilitation Canada is managing this program. So the IVAN program basically is an IVAN, which is set up like an ophthalmology office. And this van basically travels to communities in the north. Usually each year, there are about 20 to 25 spots that this van visits. And usually one ophthalmologist from Ontario volunteers his or her time at each of these spots and goes there with the van. And the van is equipped with a slit lamp, it has an indirect ophthalmoscope, it has lasers, it has equipment and instruments to perform minor eye surgeries as well. And there is some staff that goes with the van as well. So there is an ophthalmology technician, and there is other staff to help you with visual field tests and OCT images. So basically all of us go together to one location, and we are usually at that location for about 5 days. And then each of these days we would see patients inside the van and provide care closer to home for patients. So I was with the IVAN this year. We had gone to Red Lake. So just to show you, this is Thunder Bay, and then Red Lake is about a 7 to 8 hour drive from Thunder Bay further north. And this is what the IVAN looks like. So stairs are set up, and this is where the patients enter from. And then we have these sections in the van where we have an ophthalmology technician, we have the check-in area, and then this is where the ophthalmologist would be. And the inside of the van is actually set up exactly like an office. So it's actually very easy to forget you're in a van once you're inside. And during our time at Red Lake, we've seen about 125 to 130 patients there. We've done about, we did about, I think, 7 or 8 lasers and some other minor eye procedures as well. So it is nice because otherwise all of these patients would have to come to either Thunder Bay or to any other location close to them where an ophthalmologist was available to actually get these services. And because this IVAN goes to all of these spots every year, and the records from the previous years are also available. So you can actually follow up patients year to year under the IVAN program. And there is this opportunity for medical students and residents to actually shadow ophthalmologists when they go to the IVAN. So if any of you are interested, it is actually an excellent opportunity to see how care is provided in remote communities in the north under the IVAN program. Okay, so we are from clinical practice, we are going to move on to research. So at Thunder Bay, we have research ethics boards at the hospital and at the university. There is actually also a research institute, and this research institute has research coordinators and assistants which can help you with research projects. I work with some external collaborators as well. And the Northern Ontario Academic Medicine Association actually has some research funding grants that promote research in Thunder Bay. So this is the project that I wanted to talk a little bit about, and it is based on the use of artificial intelligence for diabetic retinopathy screening in Northwestern Ontario. And this is a project that we are in the process of starting with collaboration with Orbis Canada. So we talked a little bit about just before we'd spoken about how a lot of patients in remote areas and rural communities are not able to have access to optometrists or ophthalmologists for their regular yearly diabetic retinopathy screening exams. So one of the ways, so that is the traditional exam that was done for the longest time and is done even now. So one of the ways to overcome that was to use teleophthalmology. So what obviously happened in teleophthalmology was that there was an ophthalmology technician who was trained to take pictures of patients' retinas. And then these pictures were shown to an ophthalmologist who was probably in a bigger city. And then the ophthalmologist would look at the images and decide whether the patient had diabetic retinopathy or not and required treatment or not. And this information, maybe after the ophthalmologist had seen the images, was relayed back to the center which had taken images of the patient, and then patient follow-up was arranged. Now, this runs into many problems because first, we don't give the patient their diagnosis at the point of care. At the point of care is just a picture that is taken and the patient goes back home. And then whenever the ophthalmologist has time, maybe 2 weeks, 3 weeks, 4 weeks down the road, they would have a look at the images. And by the time the results go back to those communities, the patients may no longer be around. It may be difficult to get through to the patient again, bring them back for an appointment, arrange follow-up. So there were a lot of loose ends there. Also, there were issues with physician reimbursement or physician compensation for reading these images. There were also issues with physician licensing, because if the patient, say, was in Ontario and the physician reading the images was in Manitoba, then a lot of provinces would not, or the provincial health plans would not actually cover the teleophthalmology exams. There were also issues with physician liability, like if a diagnosis was missed, who was responsible? Was it the poor quality of the image? Was it the physician? Whether the CMPA, which is the malpractice insurance for physician in Canada, would actually cover physicians for teleophthalmology or not. So there were a lot of issues with teleophthalmology, and from this was kind of, to some extent, we moved to artificial intelligence and machine learning. So I'm obviously not the expert in the technology behind machine learning and artificial intelligence, but what I'll basically talk about is that recently artificial intelligence has started to move more from research into hardcore clinical practice. And there are two basic ways in which artificial intelligence in ophthalmology works at present. So one is semi-autonomous artificial intelligence, and the other is autonomous artificial intelligence. So semi-autonomous artificial intelligence basically means that the machine learning algorithm comes up with some sort of diagnosis, and then there is some sort of human intervention or physician intervention over and above this machine learning algorithm. And this together, so the physician and the AI together come up with a final diagnosis based on which treatment is planned. Now, the other way to do this is autonomous artificial intelligence, which basically means that there is no human interaction anywhere. It is just the machine learning algorithm on its own that comes up with a diagnosis. And it basically decides whether the patient needs to see an ophthalmologist or whether the patient is fine to come back, excuse me, for another exam in 1 year. And there are a number of machine learning algorithms that are now available for diabetic retinopathy screening. But issues come up here is with respect to Health Canada approval of these systems. So if we were to use any of these systems in actual clinical practice without physician oversight, these systems have to be Health Canada approved if they were to be used in Canada, or US FDA approved if they were to be used in the US. So one of the systems that is Health Canada approved at present, the company name is INUC or INUC, and that is the most, it's like ahead of some of its contemporaries in terms of approval from Health Canada. And that is the one that we are, excuse me, planning to use in this program. So our idea basically is to start this program in Thunder Bay, where we want to screen patients for diabetic retinopathy using artificial intelligence, and then hopefully build on this program, and from Thunder Bay start to move to the more remote communities in the north, where there are actually no optometrists or ophthalmologists to do those screening exams. So these are just some of the advantages of using autonomous artificial intelligence. So we can set up cameras in remote communities. Cameras can be set up in primary care offices so that when the patient comes in for their routine diabetic care exam, they could have a picture right then. So this obviously, then the patients don't have to wait for a referral to an optometrist or an ophthalmologist. They don't have to come back for a second appointment many times. And so it improves access to care. It hopefully allows for early diagnosis, and that can lead to better outcomes. Obviously, there is no need for an ophthalmologist to review images, so it reduces the burden on ophthalmologists. There are no issues with licensing of ophthalmologists or malpractice liability. It's very easy to learn how to take images on the cameras. The camera would tell you then and there whether the image quality is good enough or not. It would give you a decision at that at the point of care, so you would know whether the patient needs to see an ophthalmologist or can come back in 1 year, so you could let the patient know then and there. And a lot of these algorithms have shown very good diagnostic accuracy, very good sensitivity, specificity, positive and negative predictive values. It obviously saves the need for, so there is no need for transport or travel over distances, and it has the potential for cost savings for the healthcare system, but obviously it has to be with the participation of the community, and finally with the community taking up leadership for the program. From research, we are just going to move on to teaching, and we do get medical students who come for their clinical ophthalmology rotations here with us. There are some special educational experiences that we provide as well. As we discussed before, there are, unfortunately for now, there are no ophthalmology residency spots or fellowships at present in Thunder Bay. With respect to research projects, I just wanted to bring your attention to NOSM Summer Medical Student Research Funding Awards. So this is an award that is given to a medical student over the summer months if they want to shadow a physician to do some research with them. So NOSM basically provides a stipend for, I think, about 3 months of 2 or 3 months of research with a staff physician. And we also have some local educational groups here in Thunder Bay, where physicians who are interested in teaching and in mentorship and in research, they basically come together. And this is under the umbrella of the Northern Ontario Academic Medicine Association. Now, one of the areas of teaching that we have started to talk about a little bit more in Thunder Bay, and in ophthalmology as well, we've been trying to start that. Here is a simulation-based ophthalmology training. So the Northern Ontario School of Medicine, as we probably know, was it started with the need for physicians in the north. So the idea was to train physicians to then hopefully get them to practice in Northern Ontario. And it was based on the concepts of generalism and rural practice. So it is a great philosophy, and students from NOSM get excellent clinical experience, and all the medical students here that I've worked with are great at what they do, and they get a lot of exposure to rural medicine, and they shadow physicians all over the north as well. However, one thing that I find to be lacking is basically exposure of medical students to the subspecialties and to training in the subspecialties. So subspecialties like ophthalmology or ENT or dermatology. So unless a medical student was to choose to do a clinical rotation in these subspecialties, there is very little exposure that is provided to them during their training at NOSM. And even in the NOSM program, we've seen from 2009 to 2018 that almost 90% choose at either family medicine or the general specialties like medicine, surgery, and pediatrics. And only about 5% actually choose dermatology, ophthalmology, or plastic surgery. So we definitely need more family physicians in the north, but we also need more specialists. And we definitely also need many more ophthalmologists. And it's not just being an ophthalmologist, but it's also all physicians who are going to practice as family physicians or as emergency physicians or as rural physicians. They may not have access to an ophthalmologist, or they may not always be able to refer patients to an ophthalmologist when they are working in smaller communities. And it has been shown in a lot of studies that ophthalmology is one of the areas where clinicians report less confidence diagnosing and treating compared to other specialties. And it has been suggested that if during medical school there was a little bit more ophthalmology teaching, or if there was a more effective way of doing ophthalmology teaching, things could be different. And again, there are studies to show that even you don't have to have like an entire clinical rotation in ophthalmology, because I mean, there's already a lot that medical students have to do here at NOSM, and their schedules are really busy. So it doesn't have to be like an entire ophthalmology rotation that they go through. But even if it was a short, almost like a mini elective or a workshop, that could help students gain knowledge and skills to build confidence and be able to treat or at least diagnose and refer ophthalmology conditions better than they would otherwise. So one of the ways to do this is through simulation-based training. So using things like standardized patients, or using basic simulators, or using eye models to practice skills, and hopefully with that gain more confidence and more experience, and be able to apply that in their clinical practice, not only if they were to do ophthalmology, but also if they were to go ahead and do family medicine or emergency medicine or rural medicine. So we've just started this workshop in Thunder Bay, where, and again, we are still working on refining this, and we are just at the very start of doing this, where we want to hold this workshop for a few medical students, a small batch each time, with a few hours of training in ophthalmology using these simulation-based techniques, so that they gain more knowledge and experience. Besides clinical practice, research, and teaching, there are a lot of roles in administration, when you're working in smaller communities. So in a place like Thunder Bay, besides practice management, there are a lot of roles at the Northern Ontario School of Medicine, at the hospital. There are also many leadership positions that you could take up at the Ontario Medical Association, at CPSO, or at NOAMA. So all in all, I think you get to do a lot if you're practicing in a smaller community. I personally find it very satisfying, and I think patients and just everyone around you is very appreciative. So it's very satisfying and very gratifying. And if you get a chance to work in one of these smaller communities, I think it will definitely enhance your experience, and it will broaden your outlook to healthcare in Canada as a whole. Thank you.
All right, so thank you so much, Dr. Bhambhwani. We'll open the floor now to questions, both in the chat and via audio or video. So if anybody has a question in the chat, we'll read it out and have the answer from there.
I can ask a question. Thank you so much. This was really insightful, and I really appreciate your talk. And the way you organized it was also really helpful with the clinical aspect and the research and the teaching. What particularly caught my attention was the research and the AI. And so I was curious, for the AI program that you're going to bring into Thunder Bay, the research aspect, how does that come in? So for example, are you going to be testing like patient satisfaction or something else? Just curious about that.
Yeah, that's a great question. So with a lot of these algorithms now, there is a lot of data available on sensitivity, specificity, positive and negative predictive values. So a lot of these algorithms have actually shown that they are very, very sensitive, and sometimes they're even more sensitive than physician examinations. They may not be as specific, so there may be a lot of false positives, but they would actually at least pick up patients to be seen by the ophthalmologist. And then if the ophthalmologist sees these patients and finds out that they don't have diabetic retinopathy, then that's fine. They can just be seen again in 1 year. So there's already a lot of data available on this. And so we are not going to be looking at sensitivity or specificity in this study. What we are doing from the research side is actually to look at patient satisfaction and the patient experience of doing this exam. So this exam would actually be done by the primary care provider. So when the patients come in for their regular diabetic checks with the family physician, so they get a lot of blood tests done. They get so many other tests done anyway. So this would be just another component of the regular diabetic exam for a patient with their primary care provider. So pictures would be taken, and then we're going to have a survey with the physicians involved to see what the family physicians liked about this, whether they felt that this was easier compared to sending a referral to an ophthalmologist and then waiting for the ophthalmologist to see the patient and then get feedback and telling them what the patient had, or was this just better because they would know at the point of care whether the patient has diabetic retinopathy or not, and then they can take further action based on that. So one is the outlook of the primary care providers, and the other would be the patient outlook. So with respect to whether or the amount of value that this service provides to the patient in terms of not coming back for another appointment with the optometrist or the ophthalmologist, not having to wait that period of time to get an exam, not having to miss an extra day of work, and a lot of these can actually be done without dilating eye drops. So not having to have dilating eye drops. And also we are going to study like a cost benefit analysis of this versus the traditional referral based system as well. So try to see how much of a cost saving this provides to the healthcare system.
That sounds great. Thank you so much.
Hi, Dr. Bhambhwani. So I have one question. So you mentioned the IVAN, and you mentioned that you see patients, for example, essentially at one city once a year. So for the patients who need follow-up a little bit more frequently, how does that work? Do they get, I guess, transferred into your care at Thunder Bay and then sort of make that trip more regularly, or?
Yeah, so if they need more frequent follow-up, or if they need something that cannot be done at the van, like, so for example, if they were to need cataract surgery, then a lot of the times the physicians who are there volunteering with the IVAN would transfer the patient either to their own practice or to a colleague's practice closer to their hometown. So there is this network of ophthalmologists who partner with the IVAN. So even if they are not volunteering that year, they would still accept patients into their practice.
Okay.
So if they need more frequent follow-up, then they usually go to the practices, but they are at least still seen once a year anyways with the IVAN. And so for things like a lot of them, like stable glaucoma, for example, or stable dry macular degeneration, for example, all of these can easily be seen just once a year.
Okay, thank you.
I had a question as well. For the CNIB IVAN, I was wondering, since it goes into many of the rural communities, and I'm assuming some of these rural communities also have a large population of indigenous peoples as well, is there any support on the IVAN that is also there as part of the team for indigenous people? So for example, like a translator or sort of like a navigator?
So not with the IVAN itself, but usually when the IVAN is there, the local health center of that place knows about the IVAN schedule. And usually patient appointments are booked about a month in advance, so they know which patients are going to be coming in. But if there is somebody who needs to be seen more urgently and hasn't booked an appointment, they are still seen. But for the most part, you know which patients are going to come and see you. So they have like the local health centers provide that service, but
Right.
IVAN itself doesn't have personnel for translation or for those services, but the local health centers do.
Okay. So I guess you sort of plan it out with the local health centers then. A lot of
Exactly.
communication then. Okay.
Yes. And a lot of that is done by Vision Loss Rehabilitation Canada. So they make it easier for physicians as much as they can. And I think a lot of hard work goes on behind the scenes, which we don't see very often, but yeah, I think sometimes we don't appreciate it enough, but they do a lot of work behind the scenes.
Yeah. Seems like it, yeah.
Thank you so much, Dr. Bhambhwani. I have a question for you as well regarding the AI tool that you mentioned for screening for diabetic retinopathy. I was just wondering if you foresee this, if it is successful, if you foresee it extending to other conditions that have a high prevalence in communities that don't have as much access to primary care. So for example, I was thinking along the lines of retinopathy of prematurity. Could you see this tool as being useful for something like that?
Yes, absolutely. And in fact, there are a lot of studies on use of AI for retinopathy of prematurity screening. So diabetic retinopathy obviously has had the most studies on this are on diabetic retinopathy, but you know, any condition which in the eye that can be diagnosed based on a photograph can be basically diagnosed using AI. That's my opinion, is like you could, if you could look at the optic disc or scan the optic disc, you could look for glaucoma, you could look for vascular occlusions, you could look for macular degeneration, diabetic retinopathy for sure, retinopathy of prematurity. So anything I think that can be diagnosed with a photograph can easily be diagnosed using autonomous artificial intelligence. But I mean, I say easily because easily in concept, but obviously you need like these have to be you need these generations of AI algorithms coming in and trying to refine them and trying to make them more accurate. But in theory, or at least conceptually, I think so. The eye is amazing in that sense. So I think after radiology, so people talk a lot about radiology and AI, but ophthalmology and AI, I think, is equally. I think ophthalmology is going to be at the one of the subspecialties at the forefront of artificial intelligence, because there are so many conditions that you can just diagnose by looking at the retina or at the nerve. So for sure, I think in the long run, we may have a single device which takes a picture of the retina, for example, and looks for all of these conditions: diabetic retinopathy, AMD, glaucoma. So that could replace like the yearly eye exam that you go do for your optometrist, right? In the long run, probably there'll just be a photograph, and that could at least be a screening exam. Likely it would lead to a lot of false positives, but those can obviously see an ophthalmologist and an optometrist, and the ones that are negative can then just be made to follow up.
Thank you.
Can I maybe ask a follow-up question with the AI, if that's okay? So I think earlier you'd mentioned that there's some, with like the current model for teleophthalmology, there are like concerns with if there's a misdiagnosis where the liability might fall. So in this case, if there happens to be a false negative, how might that be navigated?
Yeah, so again, great question. And so for these, it's very interesting that it's actually the companies that take up liability. So the company that makes the algorithm would take up liability, which actually shows that they are confident in their product, and they feel that they are not going to miss. So it's important not to miss, so not to have a false negative. So there's always a trade-off for any diagnostic test. There's always a trade-off between sensitivity and specificity. So the more sensitive you make a test, the less specific it's going to be. And I think the idea of using AI for screening is that you try to make it as sensitive as possible. And if you get a few false positives in the process, that's fine. And I know of two companies. So iNook is one of them, and there is another company as well. And both of these companies, one of them is FDA approved, and iNook is both FDA and Health Canada approved, and they both take liability for their findings.
Thank you.
I had a question. Do you find it more like team-based in Thunder Bay rather than a bigger center where there's more ophthalmologists that kind of have their own practices?
So team-based in the sense that is it like relationship between colleagues, or is it like coverage in what sense?
Yeah, like you just have people to kind of rely on because you're all working in the same clinic rather than owning your own.
Yeah, so I think so, and I think so in Thunder Bay we actually have 3 practices. One practice, which is our practice, has 3 ophthalmologists, and then there are 2 other separate practices with 1 ophthalmologist each. And one of those ophthalmologists is very close to retiring. So it's basically 2 practices, one with 3 ophthalmologists and one with a single ophthalmologist. So it just depends on how you like to practice. I like to have some other ophthalmologists around me because it's nice to bounce ideas off people. There are a lot of the times you see cases or conditions which are confusing, and it's always nice to be able to get like a second opinion. And there are so many times that we don't even send each other like formal referrals. It's just like I'm in the office and somebody else is in the office as well, and I could just ask them to, hop on to just come to my room and have a look at this patient. So it's just nice to have that sort of relationship with your colleagues, because you definitely rely on them, and and I feel that it's probably closer knit in the smaller communities compared to in the bigger centers. But that's just my personal opinion.
Thank you.
Okay, so it is 8 o'clock. If anyone has any dying questions, then now would be the time to bring them up. Otherwise, I think we are going to end it there. Thank you, Dr. Bhambhwani, for taking the time to give that amazing talk. It was very insightful, and to also answer all these insightful questions as well. We really appreciate it. I had in the chat put a link for post-event survey. So if everyone could also fill that out, that'd be really nice for us to have talks like this again and create initiatives that we feel would benefit everyone. So that would be great.
All right.
Okay,
Yeah.
Thanks.
Yeah. Thank you so much again. And I guess that's it for the rest of the talk. And again, thank you so much, Dr. Bhambhwani, for sharing your wisdom, and also as well for serving the community in Thunder Bay and on the IBAN in Northern Ontario in general. So thank you on behalf of your patients as well, I guess. Thank you so much.
Thanks. Okay.
Have a good night.